Hi friends, let's discuss something about brain tumors. The key words used in this session are glioblastoma multiforme, meningioma. Let's discuss it under the following subheadings: Introduction, etiopathogenesis, clinical features, gliomas, meningiomas, pituitary tumors, schwannoma, investigations and treatment. Now you'll be wondering how to remember all these so many names of tumors. It's easy if you just remember this little mnemonic called plug 10. Okay, that is P for pituitary tumor, L for lymphomas of the brain, U for unknown primary or mets to the brain from the lungs, breast, melanoma, etc. G is for germ cell tumor, T is for tumor-like malformations like craniopharyngioma, colloid cyst, dermoid, epidermoid, etc. And then E is for extraaxial tumors, especially meningioma. Meningioma is one of the most commonest tumor of the brain, just second to the Mets. Okay, so the first primary tumor, the most common primary brain tumor is meningioma. And also vestibular schwannoma comes under extraaxial tumors. Then we have neuroepithelial tumors. Again, out of the neuroepithelial tumors, because these are very important tumors, you can just remember this by the names by this mnemonic MNOP. M is for medulloblastoma or a primitive neuroendocrine tumor. N is for neuronal tumors. O is for oligodendroglioma and other gliomas like astrocytoma, ependymoma, choroid plexus tumor. Okay, all these are gliomas. And finally P is for pineal tumors. Okay, so out of these, the ones in the italics like astrocytoma, ependymoma, choroid plexus tumor, germ cell tumor are all childhood tumors seen among pediatric age group 2. Okay, now coming to the etiopathogenesis. How does one acquire a brain tumor? Half of it is determined at birth because it is having some association with chromosomal abnormalities, and otherwise also certain tumors happen sporadically without any reason or due to environmental problems like radiation exposure. So half of it you can't determine and half of it is in your hands. So what are the chromosomal abnormalities which can lead on to brain tumors? They are all common syndromes like neurofibromatosis 1, neurofibromatosis 2, the Cowden syndrome, HNPCC or hereditary non-polyposis colorectal cancer, and Leigh-Ferroni syndromes. Now these are all very popular syndromes, right? So what are the gene defects? In NF1 it is 17 and NF2 it is 22. It is neurofibromin in NF1 and schwannomin in 22. All these can be asked as MCQs for your entrance exams. Then Cowden's is P10, the 10th chromosome. HNPCC, there are multiple defects which cause HNPCC. Leigh-Ferroni is by the P53 tumor suppressor gene on chromosome 17. Now about the tumors, you can see that most of the brain tumors syndromes cause a common brain tumor called the astrocytoma. Other than that, the schwannomin or NF2 can cause acoustic neuroma as well as meningioma. Now meningioma is important because it is very, very common. Okay, so meningioma is caused by NF2 mutation, NF2 syndrome, that is chromosome 22 chromosomal abnormality. Now coming to the clinical features of brain tumor. When do one suspect a brain tumor? What are the symptoms? Suddenly the patient has seizures. Okay, an apparently normal person has sudden onset of seizures, which are typically simple or complex partial seizures, especially in low-grade gliomas. In low-grade gliomas, the typical symptom is in the beginning is just seizures, that too partial seizures, simple or complex partial seizures, or features of raised ICP, intracranial pressure, like headache, and that too which is worse in the morning and on straining, that is raised ICP, along with nausea and vomiting. Other than that, there could be different focal neurological deficit depending on the site of the tumor, which site the tumor is and which nerve roots are affected by the tumor. Now, depending on which tumor you're having, there will be different types of clinical features. For example, pituitary tumor. Now, the position of the pituitary tumor is in close relation to the optic chiasma. So, A pituitary tumor can cause bitemporal hemianopia as well as gaze palsies. Cerebropontine angle, example vestibular schwannoma or acoustic neuroma, it is near the auditory nerve. So it can cause hearing loss, visual balance disturbances as well as tinnitus. Anterior skull base is related to the olfactory nerve, so anosmia can occur. Also optic nerve, so ipsilateral optic atrophy, contralateral papilledema because of the optic nerve passing to the contralateral side. Okay, occipital area deals with the visual problem. So homonymous hemianopia can occur in occipital tumors. Parietal area deals with your mathematics skills, the scientific skills, the artistic skills. So acalculia, agraphia, left-right disorientation, finger agnosia or the Gerstmann syndrome, all are because of parietal tumors. Parietal tumors like gliomas can also affect sensory inattention, dressing apraxia as well as stereognosis. Temporal area, what does the temporal area do? It deals with the memory. So memory disturbances as well as certain visual defects like quadrantanopia, dysphasia, all are because of temporal tumors. Frontal tumors deals with the socialization, social inhibition, etc. So personality changes, gait disturbances, urinary incontinence because of lack of social orientation. Brainstem lesions. Brainstem is full of cranial nerves, like the last cranial nerve. So multiple cranial nerve defects, long tract signs as well as nystagmus. Posterior fossa deals with ataxia, can cause ataxia as well as hydrocephalus, like the medulloblastoma tumor. Okay. Now coming to gliomas. Gliomas are an important group of tumors because they are very aggressive. So tumors of glial origin, as the name suggests, is gliomas, and the most common one is astrocytoma. Okay, there are subtypes like oligodendroma, ependymoma, astrocytoma and mixed varieties. Depending on the severity or the aggressive nature, grade 1 is cystic, grade 2 is anaplastic. Okay, grade 1 is cystic, grade 2 is diffuse, grade 3 is anaplastic and grade 4 is glioblastoma multiforme. Okay, so grade 4 is the most aggressive tumor, glioblastoma multiforme. How do you diagnose it? For that you have to take a histology, find where the tumor is coming from if it is of glial origin. Then MRI with or without contrast or the CT showing ring enhancing lesion like this. See, this is the tumor which is staying apart from the rest of the brain parenchyma. Also, you may have to do a CT abdomen, chest, pelvis also to rule out any mets. Differential diagnosis of such a lesion. When you see such a lesion, the first thing you should think of is a benign condition like a brain abscess, right? So that is a differential diagnosis. What is the treatment? Since this is a very highly aggressive tumor, you have to give high dose steroids. And when you're giving high dose steroids, you need to give proton pump inhibitors also. Okay, so symptomatic management by high dose steroids as well as anti-epileptics, because all kinds of tumors can cause seizures as the clinical feature. Also, finally, you have to deal with the tumor in the form of surgical resection. Diffuse infiltration is common, so surgery is also tough, but finally you have to deal with the tumor. Next, about gliomas again is low grade. Two types of gliomas, the low grade gliomas as well as the high grade one. In low grade gliomas, seizure is typical. Okay, seizure especially in the 4th decade. What is the 4th decade? 30 to 40 years, right? And in such low grade tumors, you can attempt awake craniotomy. You're not giving the patient a general anesthesia and making him sedated. Instead, you can try an awake craniotomy if it is encroaching on the cortex, okay, because it is a low grade tumor. High grade glioma like anaplastic carcinoma or glioblastoma, you have to do a proper surgical resection. Now, high grade gliomas are more common and it is seen in elderly like 5th and 6th decades, that is 40 to 50 and 50 to 60, right? It can happen de novo. It can just become a sporadic lesion, or it could be because of a transformation of the low grade glioma into a high grade one. Okay, what is the treatment? Of course, you need to surgically resect it. Other than surgical resection, because it is a very aggressive tumor, you may need high dose focused radiotherapy. Again, this tumor could have distant mets, so you have to treat the patient systemically. by giving chemotherapy in the form of local carmustine wafers. Carmustine is the anti-neoplastic agent used, and also you can give oral acetazolamide to reduce the ICP. Okay, now coming to meningiomas. Meningioma, as the name suggests, arises from the meninges. You have the dura mater, the arachnoid matter, then the pia mater, right? So it is usually benign. Okay, many patients come to you with meningioma because it's a very common lesion, but the good part about it is that it is benign mostly. Sometimes there are anaplastic variants also, and it's a slow growing lesion, so the symptoms will also be progressive. Usually it arises from the arachnoid matter. Okay, and 80% are supratentorial. There are three types: fibroblastic, endothelial, as well as angioblastic. Okay, just for fetching more marks: fibroblastic, endothelial, angioblastic. Now, meningiomas are symptomatic. See, this is a meningioma. See, arising from the meninges, the covering of the brain, right? Meningiomas are symptomatic because they have a huge mass effect. Like the patient may come to you with complaints of diplopia, sudden diplopia, or similar things. So when you take a CT, you might see some edema in the adjacent brain, that is around the brain. Around this lesion, you might find cerebral edema, and sometimes it can cause obstruction to the CSF flow and cause hydrocephalus. So what are the treatment? If the lesions are small, because they are benign, you can just wait and watch. If they are large and impinging on a key structure, that is, if it is causing mass effect, you may have to give hydrosteroids, and sometimes you have to end up in surgery. If it is really difficult lesions for surgical excision, then you have to give radiotherapy, or you can go for stereotactic radiosurgery. These things are exclusive for neurosurgery. Stereotactic radiosurgery. Okay, the problem with meningioma that though it is benign and though you can wait and watch, the problem is that about 30% will recur after subtotal excision and only 10% will recur after total excision, but it is notorious for recurrence. So this is meningioma. You can see so many walls over here, walls. Okay, cells are arranged in walls, and that is typical of meningioma. Next, about pituitary tumors. Pituitary tumors, as I have already mentioned, it is very close to the optic chiasma. Here you see a pituitary tumor obstructing or impinging on the optic chiasma, so the patient will be having bitemporal hemianopia. They are mostly benign. You have hypersecreting as well as hyposecreting tumors. You also have acidophil adenomas, basophil adenomas, as well as chromophobe adenomas, depending on the histology. Other than that, another key word to remember is Antony A cells and Antony B cells. Okay, these are all typical of pituitary tumors. Again, one key word about meningioma is Samoma bodies. Samoma bodies. So, other than hyposecreting and hypersecreting tumors, you also have microadenomas as a classification, less than 10 mm, which is seen incidentally, or more than 10 mm, causing visual defects like bitemporal hemianopia. Now, what do the patients complain? Because pituitary adenoma, 30% arise from prolactinomas, others from growth hormones and ACTH. Just remember these things. PGL or LPG, right? Prolactinomas, growth hormones, not PGL, it's PGA or the PG association. So, or GAP, gap. Okay, so prolactinomas, growth hormones, as well as ACTH tumors. So prolactinomas will cause galactorrhea, growth hormone excess will cause acromegaly, ACTH excess will cause Cushingoid features. So what all are the workup investigations you need to do? You have to see whether prolactin is high. So prolactin plus FSH or LH. Then to find if there are gonadotropins increased, you may have to do testosterone or estradiol. And if GH is the tumor, if the tumor is secreting GH, serum growth hormone should be checked, and adrenocorticotropin hormone, again you have to check serum cortisol. So all these, depending on which tumor you're dealing with, any particular hormone might be elevated. So how do you treat these patients? First of all, because it is prolactinoma, you have to give something against dopamine. So you have to give dopamine agonist so that the dopamine secretion is decreased and prolactin secretion is decreased. So you give bromocriptine as well as cabergoline. And growth hormone tumors as well as ACTH tumors and all, you have to give their corresponding antagonists. So sometimes somatostatin analog, somatostatin antagonist, octreotide, can also be useful. Treatment: how do you treat pituitary tumors? You have to go transsphenoid, because this area is in close contact with the sphenoid bone. The approach is transsphenoidal resection, and this may lead to diabetes insipidus. Okay, that is removal of the pituitary gland can lead on to diabetes insipidus. Anyway, what is pituitary apoplexy? Pituitary apoplexy means a sudden bleed into the pituitary tumor, which will aggravate all these features. Okay, so that was about pituitary tumor. Next is about schwannoma. Schwannoma, as the name suggests, it arises from the nerve sheath tumors. You know that Schwann cells are seen on the axons of the nerve. So schwannoma arises from the nerve sheath tumor from the CP angle, that is cerebropontine angle, cerebellopontine angle, and it is easy to remember the nerves 5, 6, 7 and 8. Okay, so this is the cerebellopontine angle, and the nerves over here are 5, 6, 7, 8. This is called an ice cream cone appearance. This is called an ice cream cone appearance. So investigation of choice is MRI with gadolinium contrast. Okay, and what are the features? Because the 5, 6, 7, 8 are affected, 5 is affected, there will be trigeminal neuralgia. 6 is affected, there will be problems with the visual disturbances, right? So squint. 7 and 8, hearing loss, tinnitus, balance problems, etc. Also, because of the compression of the tumor, there can be difficult flow of the CSF causing hydrocephalus. What is the treatment? If it is a small one, intracanalicular one, just go for a follow-up. Okay, because surgery is more harmful than not doing a surgery. If it is an intermediate lesion, you can try radiosurgery. If it is more than 4 cm, causing pressure effects and all that, you have to excise the tumor, and for the hydrocephalus, you may have to do a VP shunt or the ventricular peritoneal shunting. And what are the approaches? Translabyrinthine approach, retrosigmoid approach, etc. Also the middle cranial fossa approach. Now, what are the investigations you need to do for any brain tumor? Of course, we will start from the basic, that is X-rays. X-rays may show calcifications and suture separation depending on the extent of the tumor. The sutures may be broken off. Then we can do an isotope scan to find the functional aspect of it and to get a clear-cut idea of the extent and site of the tumor. CT and MRI are the common ones which we do for all kind of tumors. PET scan, positron emission scan. So PET scan is usually done for finding out mets, because all the hyperactive areas in the body will be picked up by the PET scan or the positron emission tomography. Now in brain tumors, how is it useful? It is useful because the brain cells which are causing tumor will be hyperactive, and so it can differentiate recurrence from radiation induced necrosis. Radiation induced necrosis will also show similar features on a CT or an MRI. To differentiate whether it is the hyperactive cells of a tumor or not, we may need to do a PET scan. Also carotid angiogram to find how the vascularity of the tumor is affected, or the vascularity of the adjacent structures are affected because of the pressure effect of the tumor. Ventriculography can be done. EEG can be done because the presenting complaint may be seizures. Okay, after that, the final diagnosis is by taking a biopsy. How do you take a biopsy? Either you can put a burr hole. Burr hole means if this is the skull, you're only putting a small hole here, and if this is the brain and this is the tumor, you can just take a biopsy from here. You don't have to open up the whole skull. So that is a burr hole, or a craniotomy. In a craniotomy, you may have to open a huge area to take a huge biopsy. Okay. Or CT guided stereotactic methods are also there for taking a biopsy. So see, this is in a CT scan. See, this is a benign tumor, because look at this smooth surface of the tumor. It might be a meningioma for all you know, but look at this. It has irregular borders. It is causing a midline shift. See, and it is highly irregular. So it is more likely to be a malignant tumor. What is the treatment? First of all, you have to deal with the symptoms of the patient, like raised ICP. For raised ICP, what do you do? Raised intracranial tension. It might be because of the hydrocephalus. So you may have to do a ventricular tapping or drainage and decrease the edema by giving mannitol, or you may have to give an emergency surgical decompression to reduce the amount of CSF. Okay, and also high dose steroids are also useful. Decompressive surgeries may be done for malignant tumors. Here you are doing only decompressive procedures, but decompressive surgeries may be resorted to anyway because it is a malignant tumor. Shunts may be done for hydrocephalus, if there is hydrocephalus, like the VP shunt, ventriculoperitoneal or ventriculoatrial shunt. Again, excision by craniotomy, the final definitive surgery. Sometimes surgery will not be sufficient, so you have to do a radiotherapy, either primarily to downstage the lesion or post-operatively. Chemotherapy, the agent used is carmustine. Other than that, we have to use acetazolamide or temozolomide for decreasing the ICP. So questions asked in this session are short notes on brain tumors, glioma, meningioma, all these things. The first MCQ, most common malignant brain tumor. The most malignant brain tumor, the most aggressive brain tumors are always gliomas, and the fourth grade is glioblastoma multiforme, that is the most aggressive one. Now, second MCQ, the chemotherapeutic agent used in brain tumor is carmustine. Just remember, a patient with a brain tumor driving a car, so it is carmustine. Okay. Next, the most common brain tumor is, actually the most common brain tumor is metastasis. If they are asking for the most common primary brain tumor, it is meningioma. Okay, but it is benign. So we have come to the end of this session. Until we meet next time with another session. Bye-bye.
Docemy.